Thank you, everyone, for attending today. I know this is a busy time for many of the practices, for those that are trying to open up or trying to figure out how to open up, or many of you are already opened, perhaps, and we'll learn more about that later in the meeting. Today, we do have with us Laura Ashley from Hicksney, and she's going to go through some of the new features of Hicksney and review some of the navigational opportunities that there are. There are some new reports. I have had a chance myself to go in and look at them, and I believe they can be quite useful. But I'm going to let Laura Ashley give us the grand tour of the new work reports and anything else that's new at Hicksney. I just asked everybody if you would sign in on the chat with your name and organization. That way Rebecca can capture an accurate attendance. And without further ado, I am going to turn it over to Laura Ashley.
Awesome. So thank you everyone for joining. I know we kind of launched the provider reports early, I would say late last year. And for the past couple of months, we've been working to refine a little bit, provide more types of reports under each category. But I just wanted to take a step back and kind of review what are these reports, just if anyone is not aware. Where can you find them? There is a video that I want to show that basically just talks about each category at a high level and, you know, how to use it. And then finally, just talking about where to find these resources. Luann, do you want to go? Yep. So really, these reports are preset reporting that helps providers, you know, improve their patient outcomes, and really adhere to that value-based model and care management requirements. As you know, Hicksney has a lot of organizations who participate as well as contribute data. And really, how we tabulate these reports are using data across the healthcare community. And what you'll find is some of your patients, you'll definitely understand, and you know, it really reflects how your patients have received care, maybe somewhere else. Again, these reports are to help you make informed decisions and how to treat your patients in their next step in care. So really, this is kind of, I don't know if all of you have access to the provider portal. If you don't, definitely reach out to your account manager. You know, my email, I think, is attached in this invite, but you could also reach out to me and I can point you to your account manager. But these reports are living within our provider portal. Next slide, please. When you think you could click on that video that just brings us. If not, I could share my screen, let me know. Okay, perfect. So Hicks Academy is our library of resources. So if you scroll down, Luann, everyone just has to enter their email address that's associated with Hicksney. So Luann, you could either use your email for AHI. Yep. You could try mine, LLUSA, B as in boy, IA, @hicksney.org. If you can't get into this, please let me know and I could contact our marketing department who could allow access. All right. And if you scroll down and go to the second row, yep, using Hicksney reports to identify next steps in care. Up, above. Next row up, yep. The first one. Yep. And if you scroll down.
Actually, would you like me to give you control? Would it be easy?
Yeah, I could do that. That's
okay.
Easy.
All right, let me do that real quick. All right, you should have it now.
Okay. I don't think, I don't have control. Let me see if I can.
You might have to share your screen, Ashley.
I'm trying to see.
It
It's
says
not
that you have
saying-
control now.
Okay. I don't know why. Oh, from your screen. Gotcha.
Yeah.
I wasn't quite understanding that yet. Sorry.
In this video, you will learn how to use Hicks reports to help identify next best steps in care for consented patients with conditions such as hypertension and diabetes. Start by opening your browser and going to www.hicksme.org. In the upper right-hand corner, hover over Log In, and then click on Provider Portal in the drop-down menu. Enter your email address and password on the next screen. If you're a Hicks user who practices at more than one facility, you'll be directed to the dashboard page. Find the facility for which you'd like to view reports and click on it to be directed to the patient search page. If you're like most users and only practice at one facility, you'll be automatically directed to the patient search page. At the top of the screen on the patient search page, click the link that says Reports. On the left side of the page, in the selection panel, you will see various categories. Each of these contain patient reports. These reports include patients from your facility's consented population whose information has been run through criteria informed by HEDIS measures to determine in which report they should appear, if any. For more information on these criteria, we have provided a clickable link to the Reports Guide at the bottom of the selection panel on the left-hand side of the page. Now, let's take a look at each category. The Gap List category contains reports for patients who need a recommended standard of care, such as an A1C lab test for a diabetic or a blood pressure reading for a hypertensive patient. The Compliant category contains reports for patients who have received a recommended standard of care, like diabetic patients who have had a recent A1C lab test, or hypertensive patients who are controlling their blood pressure. The Risk category contains reports for patients whose medical tests
Is it not loading over there?
It should. I have good internet connection. I'm not sure.
Okay, well, we could stop the video. This is offered in Hicks Academy so that everyone can definitely check it out. But we could just jump back to this
Okay.
slide. Really, what is available, and we went through compliant, the gap list, at risk, compliant, admission. So we're able to now use that section where you're able to go straight to your emergency department utilization, as well as future reports like skilled nursing and hospice admissions, quality measurements, so patients that meet a specific set of criteria used to measure the quality of care. So those are just a couple that are available right now. Recently, we did add our COVID-19 reporting. So really, this is COVID-19 allows you to see positive test results as well as negative test results, and if applicable, if they've received an antibody test as well. What's really great about these reports, recently we just went live with a couple new reports, so this list isn't exhaustive. So I definitely can see this to be built out more in the near future. Using the reports is a working list, so you're able to view multiple reports at once. So if you wanted to look at an at-risk and compliant list, you could definitely look at that at the same time. Being able to search specific patient's name or anything that is related to one of these indicators or categories, you could definitely search through there. You're able to sort by specific, you know, if you want to sort by all those with positive tests to look first, you could definitely do that. Another feature I think is very helpful, maybe you don't want to work the list, maybe you have a place where you do these calculations or you combine them with external data that you also receive from a third party. You're able to download these reports really nicely. So you have an Excel file that basically shows all your consented patients that meet any of these categories. Like I said, it's a working list. You could definitely figure out if this is something that you wanted to work into your workflow. Questions so far? Okay. So really, oops, did I not go up to the other one? I think I'm missing a slide over there. There, I think I'm missing a slide. There should be a resource slide.
Really? That could be my fault. I put them, I mixed them together, and I apologize. Let me,
That's fine. Did you want me to like share my screen instead? Would that help?
if you want to, go right ahead.
Okay.
And I will make sure everyone gets the updated slides. I apologize, Laura Ashley.
No, it's fine. It's fine. All right, let me get to this. So really, like I said, within the portal, within the provider portal report section, you're able to download the provider guide, which I could show you a little bit of what that is. The provider guide really gets into the details of how these are calculated, and just kind of more information than the general talking points that I have today. Furthermore, there are more resources. So the video that we saw is in there, as well as incorporating this into your workflow. Shows you kind of the COVID-19 reporting, as well as a general like PDF, just kind of talking about certain aspects of the reporting. Before I get into that, let me exit this. So this is our report guide within the portal. It really goes into like an overview, the different categories that I spoke about, you know, kind of like the timeline in which we calculate these, and especially into the nitty-gritty calculations for that. So if that's something that you're interested in, definitely log on and take a look. Let me see if I'll pull up my... I definitely want to show you how it looks like when I go in there. So available reporting, again, this is the 2-pager front and back that kind of explains it, kind of tells you at a high level what you could do with it. And again, it's pointing you to, you know, contact your account manager or look at the resources. Everyone with a Hicks Provider Portal account should have this already in their account. We made that as kind of when you do log in for the first time, or moving forward if you're a new user or existing, everyone should have this capability. So let me just log on a little bit and just show you. So the reports are here. As you could see, gives you the different lists. What you'll notice here, coming soon, meaning that this is a field that we're going to be capturing in the near future. Again, you could view multiple lists together. And I just want to look at the COVID reporting. So this kind of gives you a high level of how many patients were tested. And remember, all these reports are calculated for those Hicks consented patients. So know that it's a portion of your patient population who gave consent to view and access their information within Hicks. And then if you look at this, this kind of just shows you, you know, the patient's date of birth, what the results were. If they did antibody, it would show you if it was tested or not, and if it's negative or positive. And like I said, being able to download, you're able to download, and I'm just bringing this over so that it's an easy sheet for you to work into your workflow. Like I said, these are working lists. So if you, let's say, did something with this patient, you no longer want to see this, you could definitely work it as a list and always look at specifics here. And here's the report card. Do you guys have any questions on that at all?
Yeah, Laura, I do have one question. This is Luann. It was my understanding that the COVID test results did not depend on a Hicks consent being signed, that providers would get all that are attributed to them, those results. Is that not the case with this?
I don't believe it is, because this whole reporting tool pings off of consent. There are different COVID reporting that, you know, we work with New York State DOH that is the full reporting of that. But for organizations to view and access patients, they definitely have to collect that consent. So there are different types of reporting depending on what type of facility, you know, you are. So for that COVID reporting, I know that's for New York State DOH. So that's probably where you're also getting that information.
And then the other piece of information I was thinking is that I believed I understood that providers were getting alerts of any attributed life that tested positive, irrespective of the one-to-ones of the agreements. Is that not true either?
Wait, can you repeat that again?
So I was under the understanding that providers were getting an alert if an attributed life individual tested positive for COVID. They were getting that notification, whether or not there was a Hicks consent.
So I'm not quite sure on that. It could be a different, you know, if that's a feed that's different from ours. I know you would still get, you know, if obviously the patient did go into the emergency room or get admitted, you'll definitely get those general alerts, but we don't have at this time the COVID alerting aspect of it. I think, you know, one of the things is really to understand, you know, with this COVID alert, is it just understanding the use cases of them. We haven't had anyone approach us really in regard to the alerts. A lot of people chose that the reporting is great because they could download the list or look at this at a really high level and determine, you know, what do I want from this report. So the reporting is kind of the first step. But as far as the alerts, that's something that's not developed yet.
Okay. Thank you.
No problem. And just going back to the last slide. So if you aren't familiar with, you know, how to use Hicks or how to navigate it in general, we're kicking off our virtual training sessions that our account managers are presenting. It allows you just to kind of get those general walkthroughs of login, finding key information, being able to search updated information, as well as looking for next of kin contact information, view and print certain documents. The reason why I brought this up, I think, you know, it's a great refresher and kind of an opening if you want to use reports and how to use that. And the other thing is, once we do kind of this first kickoff to our training sessions, I believe the next one is really doing the provider portal report. So what we just went over. And again, it allows you guys just to, you know, join and ask a few questions and, you know, see if it makes sense with your availability. That's pretty much it. You know, Luann can send my contact information if you guys have any questions at all. again, happy to answer anything. And just an update for you guys. I don't know if you guys are aware, but Hicksney is in the middle of becoming a data aggregator for NCQA certification. So more to come with that. Right now, we're just working through the criteria and providing evidence. It's been really well received, and you know, I'm hopeful, and hopefully we could get some answers if we're able to be certified. So I think that would help you guys too.
Yeah, I think that would too, Laura, and thank you for bringing that up.
Absolutely.
For those on the line, what that may potentially mean is that in the future, you could potentially utilize Hicksney to submit data. That would be the ultimate. So it is an important activity that they're trying to get through. It, as you can imagine, going through NCQA is certainly laborious, but the benefit is definitely a positive on the outcomes. Anyone with any questions from Laura, Ashley, or anything about Hicksney for that matter? I will send Laura's contact information as well. I know many of you know who your account managers are and have utilized them. I do encourage you to work with your account managers to assure you have workflows that are working for your organization, especially now since some of your processes and workflows have changed. If it makes sense to you to have them come in and spend some time talking through your workflows to see if you can't do some more optimization with them. And perhaps not come in, but, you know, connect. I still have that concept that people are going to see each other. Okay, a couple of things on the NCQA updates. The COVID response page, I put that up here again. I think everybody by now must have heard that all the 2020 dates have been extended to 12/31/2020. If you don't have that information yet, here it is, and it's certainly on the website as well. Some of you do have dates on into 2021 because of your annual reporting dates that may have fallen into the beginning of this year. And those do not change. They don't fall back, if you will. At this point in time, they're still the same dates. The other thing is the access to the FAQs, and we provide that link right here that gives you that information. And we're going to go through some of those that have been posted. Rebecca, if you want to advance the slide for me. These are the updates from January to June, and you can see they get posted with a certain date, and you know, it kind of gives you some detail. It's, you know, specific to one item or, you know, one criteria point, and again, they give you some intent. I do know that they've been quite helpful in trying to clarify some of those points, and that's what they're based on as people ask questions of NCQA. They do look at the number of times people are asking the same question and obviously then provide an FAQ through this. I don't know if there's any specific questions about either one of these two, the CMO1 or CO4, the chronic condition to be considered under high cost utilization if it's expensive to treat. And again, I'm just going to pause for a minute for you to be able to read these and ask any questions if you have it. Nope. Okay, the next slide. Again, here's two other specific criteria. I'll give you all a minute to read it and at least raise any questions if you have of these particular items. And then here is again a couple of more that have been put up. Okay, if you have any questions about any of those FAQs or any other pieces of criteria, by all means, you can reach out to myself, to Brenda Stiles. Janet Mann certainly has been working with many of you in the North Country, as well as Jessica Schwartzman, and I think you have all those connections, so you should be able to reach out to any one of us. We did want to spend some time today talking about where are you at with your PCMH and your annual review process. And so we did provide you with a couple of questions and asked you to think about that. If you have some time here, are you using the tracker? Are people finding it helpful?
Hi, Luann. It's Amanda Wisher. Can you hear me?
I can, Amanda. Thank you.
Yeah, of course. So we are using the tracker, and it is extremely helpful. Do you want me to just kind of go through these questions and give you an update on where we stand?
That'd be great. Thank you, Amanda.
Okay. Yeah, of course. So we are using the tracker. We've been in contact with Janet Mann at the medical home. Last year's submission we did with Jessica, and it went really well. We are updating our policies and procedures, mostly to include changes related to telehealth. We implemented telehealth back in March when COVID hit, and that's been really wonderful to see the patient engagement. Feeling very excited with our quality metrics. We're definitely doing a lot to gear up for the coming months. You know, COVID kind of changed things in a way, so it's going to be interesting to see what that will look like. Whether people were accessing the ED because we had to close 2 of our clinics, or those kind of variations that may not have been able to be predicted. What we need help with, we are really motivated and, you know, just keeping on track, and Janet's been wonderful with that. We kind of are coming up with a plan to do monthly check-ins, so we're pretty good there, but just COVID kind of threw a wrench in everything.
Yeah. Is there any lessons learned from COVID that you had that you would want to share for call outs for other people if they're trying to go through any policies and procedures or any of their metrics?
Just related to, so NCQA and our community service plan are kind of related in the fact that we try to align our community service plan to meet the certain metrics for NCQA, DSRIP in the past, and the ACO, and really just being aware of, even though COVID has hit, we still have certain requirements that we have to meet. You know, the entire world kind of stopped on us, but now that we're getting going again, just being aware of what we have to do before the end of the year.
Okay, that's a good point. Anyone with questions of Amanda, or anyone else that has some feedback about any of these questions?
Hi, it's Brenda. Amanda, could you just, you know, you mentioned that you're getting back on track and doing monthly meetings, but you also said, you know, kind of like assistance or direction. What, you know, kind of what were you talking about? What other things are barriers or ideas that you have that may be supportive, you know, to help support your efforts in the practice? You know, because I think you know, thank you for speaking up, because I think it just, you know, kind of, it helps to align everybody on the call that everybody's going through the same thing. And, you know, what are some of the opportunities? And certainly if you don't feel comfortable, you know, saying it, please send it out to, you know, Luann or myself, so that, you know, when we're talking about opportunities or how we can best support practices, that we can take those things into consideration.
You know, Brenda, that's a great question, and the tracker is very helpful with that. But I think a timeline, like if you broke it down in a year's worth of timeline, like you should be doing this in this month, and because everybody is going to be different, we're all in different places in the process, but just kind of like a ballpark overview, so that way you have you know, temporary deadlines. You can submit things for review to your partners. Jeff I think she's on the line. She can attest that last year was crazy. You know, we kind of waited until the end of the last hour, not because she wasn't keeping me on track, but because everything was hitting all at the same time. We went through the ACO audit, we went through the community service plan and NCQA all within weeks of each other. So just definitely keeping a timeline of when you should be doing what.
And I think, you know, for everybody that is or is not part, you know, I think unfortunately, you know, January and February, I think for any organization, I know there's no SQHC that's on right now, and also the organizations that are participating in CPC Plus, January and February is the data time, right? Data is the time to close out the previous year, and the measurement begins at that point. So, you know, I think, you know, those are helpful for us to remember, and also to include, you know, for the participants that are doing the data extraction as well as the, you know, organizations. And so January and February, I think, are pretty busy months for everybody. So then looking at a timeline, you really need to double up then going forward, or, you know, to, you know, like you said, each practice is a little bit different, but I'll take note of that.
Yeah, we can work on a timeline, at least to your point, Amanda, a high level one that might just give you some indications as to those pieces that do take a little bit longer that you want to hit up early on versus some of those criteria that are not as labor intensive or time consuming. So between myself and Brenda, and we can work with Janet and Jessica to see if we can't come up with something.
Yeah,
that's great.
That's really the only feedback that I have is, you know, we all know the measures, we all, you know, participate actively in getting what we need done, but just highlighting those measures, especially the ones with reports and processes, you know, putting those towards the front of the timeline.
Yeah, that's an excellent suggestion. Thank you for that. Does anyone else have an opportunity that they'd like to share with, or things that they've been doing either with the tracker or trying to keep on target with PCMH? Abe, can I call on you? You might be muted.
There, can you hear me now?
I can, thank you.
Okay. Well, right now we're on track to pretty much have everything ready. We're just over the summer, like a lot of our reporting stuff, we just need the time for the data to accumulate for us. And actually our quality measures, even through all the COVID, we actually were able to improve on many of them. Just
That's
with our
wonderful.
shift to telemedicine. But actually the one problem we're having right now is I just learned like about a week and a half ago, for some reason, New York State's not recognizing our recognition from last year. So we're not getting any, well, we're getting some of our monies, like some payers are paying us, but other payers are saying that since we're not on the list, they're not going to pay us like our per member per month. And nobody seems to be able to fix the issue. Everybody tells me to talk to somebody at NCQA. I sent them a request about it because New York State said to talk to them. They simply just closed my question. They just sent it back and said that's not our problem and closed the case.
Excellent. Wow.
So
that's interesting you say that. We have other partners. I have another partner I'm working with, and they've run into a few glitches with some of their sites that they're questioning whether or not they're getting paid on them. Again, I'm trying to do some homework. So if I can assist in any way, I certainly would be happy to. So you're saying some of the payers are not seeing your certification?
Yes, they say that they can only look at the list that's on the Health Commerce site, and for some reason we're not on the list on the Health Commerce site. I cannot find anybody that can tell me how we can get that rectified. I've emailed the PCMH at the New York Department of Health.gov that you're supposed to go to. All you get from there is this automated response that just says, call the insurance company that's not paying you. And the insurance companies all tell me, no, you got to talk to New York State because you're not on the list that they send us, so we're not going to pay you. But then our fee-for-service Medicaid, I talk to them, and they're like, we have no idea what you're talking about because we see your recognition, and we're continuing to pay you the extra on the fee-for-service level, the bump in pay, so we don't know what you're talking about.
And they see it on the Commerce site?
They don't look at the Commerce site. They just look at NCQA. So,
Right.
But the managed Medicaids have to look at the Commerce site and the list that gets published every month. For some reason, our practice fell off the list.
Okay.
So,
Well, I don't know if I can be of any help. Sounds like you've done a ton of homework already, but
there's nobody that can fix it.
I'll see what I can find out anyway.
I mean, because Jolene Munger was, the last time this happened, she was the one that was able to actually help us fix it.
Okay, I'll reach out to Jolene. I still have contact with her and see if there was some mystical, magical thing she did. She definitely has a way about getting NCQA to see their ways. So I might just have to take the Jolene Munger method.
Well, it was, I think it was an issue of New York State and NCQA last time had to actually talk to each other to reconcile, but last time, nobody saw our recognition. Our level 3 recognition for 2014 standards was just not being seen anywhere at New York State. It just wasn't getting over there. But this time, it's like it's getting there, but then it's not getting on the list. So I think it's a New York State issue, but I don't really know because nobody wants to actually look at the issue. They're all just like, it's not our problem. It's somebody else's problem.
I'll take a look, Abe, and I'll get in touch with you as I reach out to places and see what I can figure out. That is very frustrating. You do all this work and then, you don't get paid for it. Is not a good idea.
Yeah, because as we're working on our recognition, it's like, if we're not going to get paid, why bother doing all this work?
Absolutely. Absolutely. And both NCQA and New York State PCMH are pushing everybody to get this recognition. We need them to, participate in managing some of the issues. Okay. Outside of that, your trackers, you said you're on target with your quality metrics. You're seeing some good results from your quality metrics. That's interesting to hear because, I think everybody was anticipating some challenges of the quality metrics, but it seems like given the telehealth opportunities, there's been many an organization that's been able to stay on track with those.
We did notice a new, I guess you could call it a disparity of care, at least within our telehealth population. I mean, that normally our commercial patients lag behind on a lot of the measures for whatever reasons, but under COVID, with our use of telemedicine, we've actually made progress with, when you look at it, when you break it out by commercial versus managed Medicaid, Child Health Plus, the commercial payers, we actually made ground on. That's where we were making our improvements, but actually our Medicaid population, we actually fell backwards. Same thing with like the vaccinations. We were able to, because we were doing vaccinations like in the parking lot and things where commercial wise, we were able to stay on track, but our Medicaid, and I think a lot of that is they don't have access to the internet or the resources to be able to properly access the internet. So we did see a slight drop with them while we made progress with our commercial patients.
That might be something we can take back, Brenda, and see if we can even look at the region as a whole to see if that is a challenge. As many of you know, we've been touting for a long time, and now even more so, the challenges around people having connections to, bandwidth, Wi-Fi, if you will, and being able to get those connections and keep those connections to get the right care to the right people. But yeah, that is disheartening that, those that potentially need it the most aren't getting it. Okay. Anyone else have anything they'd like to share that they've been working on related to the PCMH? Brenda, do you have anything to add or any questions you'd like?
No, I don't have anything, but I just think that, you know, to add to that, other than the fact that as you move forward, some of these barriers, and certainly Abe, I'll be talking to Luann a little bit later, and I just think that those opportunities, when things like that come up, certainly, you know, let us know so that we can try to navigate, because if you're experiencing it, there are other people across the region that may be experiencing similar things, or like you said, if the right person is not being contacted, and certainly, you know, we'll follow through, but we're not out, you know, in the trenches seeing what's happening day to day and what are the barriers, not only to patient care, but as far as your practice to be able to do what you need to do and carry on day-to-day activities. You know, certainly, you know, from ACO, you know, with our interactions with some of the payers and/or, you know, with Luann on their, you know, on her end with all the NCQA connections, because they, you know, provided that for the last couple of years. They do have, you know, further insights and people that we can reach out to as well. So, you know, don't hesitate to reach out to us.
Absolutely, and I would just echo that same sentiment that Brenda did. We are there to help you, and Brenda and I work very closely together to try to follow up on things that we hear or partners that, you know, raise questions. So we're sharing readily how to manage some of the challenges and trying to come up with solutions for people. Okay, the next slide, Rebecca, please. Reopening. I guess this is just the last little bit, and truly, if you have any other questions, please raise them. But how are people doing with reopening? Do you need anything? Are there still a lot of pain points? And again, I offer up, both Brenda and myself, if there's things that are going on that you might need some help with, you know, just give us a quick email and say, hey, we're struggling. Do you think you can help? And we certainly will do our very best to help figure out a resolution. And obviously, if we can't, we can't, but we've been pretty successful in trying to manage some of the challenges that have come up. So with that, does anybody have any words of wisdom or challenges they've been experiencing with trying to reopen? How are people doing with, go ahead.
So I'm just going to throw this out there. Some of the conversations that I've had with some of the other practices, and I know they're not on today, and I guess I'm just curious with anybody that's on, has anybody for after-hour calls, now that you have the ability to use telehealth, are your providers using telehealth as a means of being able to do after-hours call? You know, I know that in the North, we do have a on-call service that is utilized, but I was just wondering, you know, if your providers are doing that, you know, what other changes, what other things are you doing with telehealth within your practice that would not have been considered otherwise? You know, just different utilizations of it.
This is Abe. We have like talked about using it for after hours. One of our providers did test it a little bit on a weekend with a couple of her calls, but we're not really sure because we want to try to keep that balance between, you know, the providers having a life outside of work,
right.
Even when they're on call. So it's like, and you know, the expectations to the patients. You know, providers don't really, because we occasionally you do get that call for a, you know, a fussy baby at 2 o'clock in the morning, and the providers are like, I don't really know if I want to do telemedicine, you know, when I just rolled out of bed to answer a call.
Right.
But we have been actually, we took this opportunity now that we've been fully reopened now for about a week, and so now we've been taking that time to, like, we've reevaluated how we've been using telemedicine, like now that we've actually had some significant volume to be able to see, you know, after doing a few thousand visits, to see what works and what didn't. So we've we started crafting a policy for our staff of like what's an appropriate telemedicine visit, and you know what we're as a practice are going to use for a guideline to try to I mean, I think the one area where we think we're going to probably use it a lot more is those patients that call, the families that call with like a question, and instead of just giving our resources out for free, you know, if it's like a feeding question for an infant or something, do a telemedicine visit instead of just calling them back and then playing phone tag because they're not there when the provider tries to call them back. Because we figure if we give them a set, here's your telemedicine appointment, we're going to call you at 11 o'clock, they'll, you know, or, you know, you can talk to the doctor at 11 o'clock with a telemedicine visit, you know, it'll be more productive for everybody.
That's a great point, Abe. I really didn't think of it that way. I know that the providers that I talked to that, you know, we were discussing, the utilization was certainly an adult med practice. So the thing is when they're, you know, if you have multiple providers in a practice covering for an elderly person, and it's not your patient, and you get a call in the middle of the night and they're short of breath and everything else, one of the providers I was on, she said, you know, during the week when I'm on call, I may get 7 calls a week. So, you know, to her, it was not, she said, but when I'm able, you know, to be able to bring them up on to do a telehealth visit and to be able to lay eyes on the person. And then also I can see what's like behind them or around them, or at least get a view into, she said, when I don't know the person, she said, it helps me to make a better decision, you know, about the care. And certainly I hear you, waking up at 2 in the morning and trying to do a call with a fussy baby. I'm not sure I would want to do that either, but I think, you know, depending upon the situation, and I kind of like, you know, it'd be interesting, and, you know, I don't know your willingness to share, but as we move through this, I think everybody that's on this call will be working towards developing their policies, you know, around telehealth and best practices. And your points, I think, are really valid. And I think, you know, sharing those type of ideas in this forum would be really helpful, you know, as we move forward. And I think, you know, the only way we can get better across the region is by sharing, you know, the experiences that we all have, the good, the bad, and the ugly, because I think we've all tried things that have utterly, you know, we thought was going to be the best thing. And then ultimately it was just like, no, this, you know, we can't continue doing this. And I think it's all right to do that so that some of us don't go down the wrong path that somebody else has already been down. So, you know, thank you for sharing that, because that's, you know, that's helpful. And I think those could be areas of future conversation, especially if we are working through towards that, you know, getting through the next iteration of NCQA this year. There's certainly new policies that are out there and that are being developed, and you know, and being able to help one another out, that may be another opportunity.
Yeah, I mean, we're not like completely saying we won't use it for after hours. It's just at this point, we're not ready to do that because we feel that it has to be, we have to be consistent with all our all of our providers have to be on board that's what we're going to do. Because, you know, we want, if the patients have this expectation that you can have a telemedicine visit at, you know, you can call at 8 o'clock at night and we'll do a visit with you, then all the providers need to be on board with that. And we have a couple providers that are, they begrudgingly do the telehealth because we've told them that that's what they have to do. But we have one of them is retiring, and we have a new provider coming on board next month. So, you know, as dynamics shift, you know, we're continuously reevaluating things and changing things up and how we do things. So, it, you know, in the future, we will probably get there. It's just right now we don't know if we're ready to take that jump.
Yeah, I was just bringing it up as a point of conversation, and to be quite honest, I didn't even think of that, you know, it's setting that expectation. And I was looking at it, you know, from, you know, certainly a different perspective, and not even thinking in terms like that. So I appreciate that feedback. So.
Sure.
Anyone else with any comments? And I think too, with some of the other groups that we've been working with throughout this time, we are trying to get anybody's feedback on how they're utilizing the telehealth, telemedicine piece and trying to identify some best practices. So as we get clarification and more organizations open up and are trying to bring about some of those ongoing utilizations of telehealth, we will certainly share with you all. And if you've come up with a best practice that seems to be working well, I would ask the same that you share. Maybe we'll put the telehealth topic on the next agenda just to keep it in the forefront of all of our discussions as people begin to utilize it more and more and make it part of their usual practice and not just the COVID response. I don't really have anything else unless anyone else does. And if there are topics, thank you, Rebecca. Just again, some call outs around additional resources. And we do the COVID newsletter Mondays and Wednesdays still, and AHI certainly is filled with information on COVID. I know too the ACO site is as well. We'll include that site here when we send out the final of this to make sure everybody has both of those sites. And just if you have any suggestions around agenda items or topics you want, please don't hesitate to send them to myself or Brenda, as we certainly are willing to talk about those topics that are most pressing to your needs. We will keep the PCMH on our agenda items just as people get back into their daily routines and looking at some of those criteria to see if there are any pain points or if we can share information that people might be able to benefit from. And with that, I really have nothing else unless others have questions or comments.
I have one more thing, Luann.
Sure.
Laura, I just wanted to thank you for the information that you presented around Hicksney, and this just came into my mind, and I don't know why I didn't connect it when you said it, but when, the work that you're doing, the work that Hicksney is doing around NCQA is vital when we look at the work that we're doing in the ACO and our quality metrics. And I know that Laura could probably, certainly that could be the next iteration, next time that we have a call, is looking at the measures. New York State is swiftly moving in the realm of the electronic clinical measures. So it is going to be imperative that we are all on board, because, right now we're all, unwilling. I don't like it. I hate sending gap lists out to anybody because it makes me cringe, because I know the work is being done in your practices, but that's the only thing that we can do in order to get the recognition for the great work you're doing in your practices, so that we can get, number one, get our quality measures up, and our measures are up. But you're chasing claims all the time. Sometimes you submitted a claim, it's been denied, or you don't know that they didn't receive it in the right format, so then it comes up on the gap list. So, the more work and certainly aligning our work and being able to utilize Hicksney is going to be the way that we can close those gaps and ensure. So the work that they're doing around NCQA, I guess, is just extremely important. And for us, as we go forward, moving to the electronic HEDIS measures. So.
Absolutely. Laura, do you have a time frame when you're supposed to hear, or is it just whenever?
Somehow I feel like it's whenever.
I was afraid of that.
It's just the test that they gave us is it takes a lot of time, but we've achieved, all the tests that they provided, which is really good thus far. My estimation is probably in the fall, but don't take my word for it.
Okay.
Yeah.
So Laura, when we had a call it's going on a month ago with Marcus, and because I want to require, I cannot believe her name escapes me. I apologize. But anyway, certainly there was a huge push. I mean, she's the one that's been working with NCQA around the RIOs and the work that's being done. Lindsay Kogan.
Lindsay Kogan.
Okay.
Yeah.
So anyway, Lindsay, you know, just said that the state, as far as she, you know, is the director of the QAR program, and the big thing is, she just said that, you know, push comes to shove, we have to rip the Band-Aid off and move forward with the, you know, and submit this way. That, you know, the claims thing is just not doing what we need it to do to accurately measure what our providers are doing. And so, you know, I know that she is strongly pushing and working with NCQA that all of this validation stuff that's going on right now, some of it, she said, is pretty tedious, and she's, you know, certainly, you know, from DOH standpoint, there's a lot of push to get this done sooner than later.
Yeah, and you know, we're on board to kind of meet all those sooner rather than later. But I am hopeful, and I feel like it would be sometime in the fall. But to your point, very tedious task, but something we can't, you know, something that we could accomplish. So that's good news.
Lindsay, let me ask you this. Do you have kind of a list of the quality metrics you're working on? Or is it, I mean, I'm sure there's a subset. It's not all HEDIS metrics. Do you know that?
Who are you talking to, Luann?
Laura Ashley, I'm sorry.
Oh, can you repeat it? So asking if all these are just pertaining to HEDIS?
Well, I know there's a list of quality metrics you're working on. Do you have that list? Is that something we could talk about at the next meeting, maybe?
Yes, I'll send, what I'll do is I'll send like the portal guide. I'll send kind of the resources if you want to take a look at that. That will give kind of like the nitty-gritty stuff. And then absolutely, if you have questions, we could definitely regroup. I probably might need the resources who kind of worked on that a little bit more that can speak to it. But yes, let's start from there. And if we need another meeting, happy to do so.
Okay, that'd be great. Thank you.
You're welcome.
Okay, folks, we are 2 minutes over. I apologize for keeping you because I know you're all trying to get your day started. Thank you again for attending, and we will talk to you all soon.
Thank you, guys. Have a good day. Bye.
You as well. Thanks again, Laura Ashley.
No problem.